Hello everyone, this is a video about muscles of mastication collaboratively done by Faseeha, Hameed, Divakar, Hahini and Harisneha. Muscles of mastication play a very important role in grinding and chewing. People having problem with grinding and chewing develop temporomandibular joint disorders. The arterial supply of muscles of mastication is maxillary artery, which is a branch of external carotid artery.
I am going to talk about temporalis, which is originated from the temporal fossa, where there is a swallow depression on the lateral aspect of the skull, where attachments are, it's originated from the temporal fossa, where it is attached to the coronoid process of the mandible. Actions are like elevation of mandible, which helps in the movement of jaw, and there is retraction of mandible, which is present on the posterior surface of the lower jaw, where it has innervation, which is a mandibular nerve, and it has two arterial supplies, which is external carotid artery and maxillary artery.
Hello guys, now I'm say about masseter, and this is masseter. It is one of the strongest muscle among the four, and if we talk about the attachments, it has two parts, superficial and deep. Superficial part originates from the maxillary process of zygomatic arch, and the deep part originates from the zygomatic arch of temporal bone. And if you talk about the function, helps in elevation of mandible, like this.
Here I'm going to talk about medial pterygoid muscle. It is actually a quadrangular shaped muscle with two heads. One is superficially placed and other is a deeply placed muscle. Superficial head originates from the maxillary tuberosity and the pyramidal process of palatal bone, and the deep head originates from the medial aspect of the lateral pterygoid bone, and both of these heads get attached to the ramus of the mandible, which is in the angle of the mandible. And coming to the actions of the medial pterygoid muscle, it helps in the elevation of the mandible and side to side movement, and it also helps in the protrusion of the mandible. And when it comes to the innervation of the medial pterygoid muscle, it is innervated by mandibular branch of facial nerve.
So this is lateral pterygoid. Lateral pterygoid has two heads, upper head which is smaller compared to the lower head. So upper head originates from the infratemporal surface and crest of greater wing of sphenoid, and lower head originates from the lateral surface of the lateral pterygoid. And if you come into the insertion, upper head is inserted on the pterygoid fovea, and lower head is inserted on the lateral surface slightly above than the point of origin. The nerve supplies by the anti-division of mandibular nerve. So if you come into the function, it just depresses the mandible so that the mouth opens, and it also protrudes the mouth, which helps in the biting.
Now let's see about palpation of masticatory muscles. Palpation is the examination of the soft tissues using the sense of touch. Palpation of the masticatory muscles will reveal tension or tenderness, which can be related to hyperactivity of the muscle as a result of overworking it in an uncoordinated manner. To palpate means to press lightly on the muscle. In a continuous movement, slide your finger along the length and width of the muscle while asking the patient if he or she feels any tension or tenderness as you apply pressure. You are also trying to feel for any abnormality, contraction or enlargement of the muscle. Now let's see about medial pterygoid muscle. The medial pterygoid muscle is a thick quadrilateral muscle which can be accessed from inside the mouth behind the third molars. Ask the patient to open about 10 to 15 mm from the intercuspal contact. Slide your forefinger posteriorly along the buccal surface. Palpate the muscle by pressing medially as well as posteriorly superiorly. Ask if the patient feels any tension or tenderness. Now let's see about masseter muscle. The masseter muscle extends from below the cheekbone down to the jaw directly over the molar region. If you ask the patient to clench and hold, you will be able to locate this muscle easily. The muscle can be palpated within the patient, clenching or relaxed. Palpate along the entire muscle length and width while asking the patient if there is any tension or tenderness. The muscle will feel swollen or enlarged in a heavy clench or grinder. Next, coming to the temporalis muscle. The temporalis is a broad fan-shaped muscle situated at the side of the head. By asking the patient to clench or hold and repeat, you will be able to locate the temporalis and follow its shape or form up, the side to the top of the head. Palpate along the entire length and width of the muscle while asking the patient if there is any tension or tenderness. The temporalis muscle is the focus of many headaches that respond favorably to occlusal correction. The muscle is also in direct opposition to the lateral pterygoid. It has some origination behind the lateral wall of the orbit of the eye and can be a source of sharp pain behind the eye. Its aponeurosis extends as an innervated sheath to the top of the head and when inflamed can make the scalp sore to touch. Temporal headaches and pain are some of the most common symptoms related to occlusomuscle imbalance. Then coming to lateral pterygoid muscle. The lateral pterygoid muscle originates from the lateral pterygoid plate. It is divided into two sections, the inferior lateral pterygoid and superior lateral pterygoid. The lateral pterygoid is a short, thick muscle which functions to translate the mandible and is active on mouth opening and near final mouth closure. While palpation of the lateral pterygoid muscle, it is not practical. It can be tested effectively to determine if it is a source of pain. Ask the patient to protrude the mandible slightly and at the same time apply pressure on the jaw distally to provoke a muscle response. A sore muscle will respond to this test. Thank you.
I will be speaking about the physical consideration. First comes the border molding. There are two muscles that are involved, are masseter and medial pterygoid. Masseter, when a masseter is activated, it pushes the buccinator medially against the denture border in the area of retromolar pad. And this is due to the dislodging force, where the denture base should be contoured to accommodate this action. This contour of denture base is termed as the masseteric groove. Then comes the masseteric notch action of denture border. Here, an action masseter muscle will create a concavity in the outline of distobuccal border, and a less active muscle may result in the convex border. Then comes the second muscle, that is medial pterygoid. It is one of the muscles that influences the denture border in the region of retromylohyoid. It also elevates the mandible. Then comes the second type, that is the border extension. Here also there are two muscles that are involved, that is masseter and medial pterygoid. Masseter, the distobuccal fringe of the denture base is not concave to allow the freedom of masseteric action, where the denture may displace. The masseteric notch buccal fringe must concave medially. The masseteric notch buccal fringe may converge medially to avoid displacement due to the construction of masseteric muscle. Medial pterygoid, then care should be taken in the lingual fringe, which should not over exceed as lingual nerve, as it is closely related to the lingual fringe. Then comes the centric relation. Here also there are two muscles that are involved, that is temporalis and lateral pterygoid. Temporalis is the most posterior fiber which pass very close to the condyle, where the posterior temporalis function as the stabilizer of temporomandibular joint. It also suspends the mandible in the centric relation as the anterior group of fibers which are aligned vertically when holds the mandible in the superior most position. Then comes the lateral pterygoid. It closes off the mouth in the backward grading of articular disc, and condyle is controlled by the slow elongation of lateral pterygoid. It also acts as a stabilizer of temporomandibular joint. Then last, occlusal harmony. Unilateral failure of lateral pterygoid muscle to contract results in the deviation of mandible. Bilateral failure results in the limiting opening of mouth.
Here we are going to see about masticatory muscle disorders. Some of the common masticatory muscle disorders involve trismus, bruxisms, tetanus, congenital hyperplasia or hypoplasia, hypermobility or hypomobility of the muscles, muscle pains, myositis, temporal tendonitis. Now we are going to see about trismus. Due to prolonged tetanic spasms of the jaw muscles, by which normal opening of the mouth is restricted, the restricted jaw movements regardless of the etiology. It is commonly caused due to arthritis, condylar fracture, irradiation, and temporomandibular joint disorder dysfunction syndrome, and tetanus. Now, the problems associated with this trismus are eating issues, oral hygiene issues, swallowing issues, and joint immobilization. And the treatment involved are heat therapy, warm saline rinses, and passive muscle stretching exercises. And then next it comes to bruxisms. Bruxisms is the clenching or grinding of the teeth when the individual is not chewing or swallowing. It can occur as a brief, rhythmic, strong contractions of the jaw muscles during eccentric lateral jaw movements or in maximum intercuspation, which is called clenching. The cause is associated with stressful events and also non-stressful events or hereditary events. Bruxisms may be related to tooth wear, fracture of the teeth or restoration, muscle hypertrophy. And then increased muscle tension is directly related to the stress activity during the day. The treatment associated with bruxisms are coronoplasty and maxillary stabilization appliances. And then next it comes to tetanus. Otherwise it is called as lockjaw. Tetanus is a disease of the nervous system characterized by intense activity of the motor neuron and resulting in severe muscle spasm caused by exotoxins of the gram-positive bacillus Clostridium tetani. Clinical features associated with tetanus are mainly pain and stiffness of the jaws, neck muscles, with muscle rigidity producing trismus and dysphagia. Rigidity of the facial muscles, sometimes whole body can be affected. Treatment associated with this are all patients should receive antimicrobial drugs and active and passive immunization or surgical wound care is commonly used as a treatment. And then next it comes to congenital hypoplasia or hyperplasia. Here, which is a rarely occurring and it's more commonly seen in masseter and orbicularis oris. Its oral symptoms include enlargement or decreased size of the affected muscles, which may show asymmetric facial pattern and stiffness in temporomandibular joint. It may or may not be associated with hypermobility or hypomobility of the muscles. Hypermobility of the muscles or the hypomobility is again a disorder which involves an extreme or diminished activity of the masticatory muscles. Its etiology includes various factors such as Parkinsonism, facial paralysis, nerve decompression, secondary involvement of systemic diseases.